Welcome back, everyone, to Einstein's Eyes. I'm your co-host, along with my two colleagues and friends and former co-residents back at Albert Einstein College of Medicine. So I'm called Rosen, Oculoplastics, Neuro-Ophthalmology, Anchorage, Alaska, at Ophthalmic Associates for the past 30 years. Today, we're going to dive into a topic that affects lots of folks, especially as we age: ectropion. Now, we do have a video on entropion, which is the eyelid turning in, and this is the opposite. This is where the eyelid turns out. So if you've ever seen somebody with a lower eyelid that droops or turns out, it makes their eyes feel dry, irritated, red, prone to infections, and tearing. It's really uncomfortable. But we got a guest that's perfect to help us understand this better. My friend, my esteemed colleague, my favorite oculoplastic surgeon on planet Earth. I'll go even beyond that. In the universe, Dr. Phil Rizzuto. Phil is an outstanding person, and he's an oculoplastic specialist. Welcome, Phil. But before I do that, Phil, hold 1 second. John, say hello to our audience.
I'm getting some internet instability, but hello. From Northern New Jersey. I've been in practice 30 years. It's great to see Phil again, who is a co-resident. And I'm excited to hear about, in belly button language, it's an innie or an outie. This is an outie we're doing tonight.
Phil's a professor at Brown University, on staff at the Department of Ophthalmology. We're really delighted to have him. Always great to see Phil. So, Phil, let's start with the basics. What exactly is an ectropion for our audience, and why? Why does it happen?
Well, first of all, Carl, thank you for the kind introduction. John, wonderful to see you. Two of my favorite people on the planet, two of the best doctors. And if I learned anything, Carl taught me everything there was to know as a resident in oculoplastic surgery. So I am half the man that he is. So thanks for the education, Carl. So ectropion, as an eyelid specialist, we see a lot of it. Ectropion, John, perfect. It's an outie. The lower lid turns out. And it's something that we see often related to gravity and time. I hate to say aging, but gravity and time. The strength of proteins in our skin can weaken a little bit. The support structures in our face can weaken a little bit. The mid face and the structures in the face fall a little bit. And when it falls, the eyelid can kind of fall with it and get turned out. And that's the most common ectropion we see. We can also see ectropions from trauma. If somebody had an injury and there's a scar there, that's called a cicatricial or scarring type of ectropion, where the eyelid is turned down, pulled down. And then there's another type of ectropion, which oftentimes is seen with nerve damage, some occasional tumors, previous surgery, skin cancers, where the nerve going to the muscle doesn't work anymore. The eyelid can't stay into the position, and it turns out so the eyelid muscle is paralyzed, and that's a paralytic ectropion. Ectropion there, and you can see that the lower lid is turned out. And it's a really classic appearance of what can happen when the eyelid turns out. And I always tell my patients it's kind of like a spiral. So the eyelid gets weak, it turns out. If it gets turned out, it gets dried out, it gets irritated, it swells. If it swells, it gets heavier, it turns out more. It gets redder, it gets more irritating. And as Carl alluded to earlier, itching, pain, irritation, discomfort, tearing, and you can see because of the outie, the tears are just going to roll down there, and constant tearing and irritation are a problem. So this is a classic appearing ectropion, and you can see the corners of the eye, they look loose. They don't look like they're attached to where they used to be. Hence, where the proteins and the attachments of the eyelid are weaker, because the face is falling down and gravity and time is pulling everything down. So this is a picture of a classic ectropion. You can see on this one, it looks like the corner, the outside corner is still attached, and that's great, but the medial ectropion is turning out. And you can see the redness that I spoke of, and because it's turned out, it can get dry, it can get irritated. And then as Carl's pointing out, there's some debris and crusting that you can see because the tears can pool there, but also skin cells, bacteria can pool there. And that's really what causes a lot of the discomfort for people. So the ectropion can be towards the nose, medial, towards the side of the face, lateral, across the whole lower lid, a classic ectropion, all of which cause redness, irritation, and discomfort, lots of tearing, and unhappy people.
Let's talk about solutions. So what are some of the treatment options for ectropion? And we'll start with the least aggressive and then get to surgery. So what do you do for your folks if they can't have surgery?
So if you looked at you look back at there, just remember those pictures. You saw that crusting that was on the eyelid, and go back to my story about how there's a spiral with swelling and redness. I always teach people how to clean their eyelids, eyelid hygiene, warm compresses, gentle cleaning, gentle scrubs to get the debris off the eyelid that might be associated with the ectropion that's causing more swelling, more irritation. And sometimes just by cleaning the eyelid and using moisture drops, the dryness is better, the lower lid swelling is better, and the eyelid can kind of go back into a better position. Still, gravity and time is playing a role, but I always try conservative treatment first. I'll also try conservative treatment and stress it to be continued because it's always going to make the people feel better, even after our surgeries. They should always maintain gentle cleaning, gentle eyelid hygiene, warm compresses, and keep the eyelid in a good position because if they do have a surgical repair, you want the eyelid to be as healthy as it can be without getting into that spiral again. So that's conservative treatment with eyelid hygiene. Surgery can be performed too, and as I mentioned, there's looseness of the eyelid. So the mainstay of treatment is tightening the eyelid and reestablishing that tension, putting it back into a better position. Carl showed a picture of a medial ectropion, and you would want to try and do that tightening oftentimes laterally, but in the medial ectropion, sometimes there's a small procedure we can do to make sure that the inside of that eyelid or the medial or area closest to the nose is in a better position so the eyelid is all uniformly closer to the eye. And then lastly, with some of the ectropions, the tension of the eyelid pulling down is too great, and you have to do a procedure where you free up some space in the front. And by freeing up the space, you can put a graft in there or a skin graft to allow the eyelid to move up more so that you're really reducing the tension, pulling it down, allowing it to move back into place. And when you tighten that eyelid, it stays into better position because you've reduced that downward tension. So there are surgical procedures for it. Always try conservative treatment and maintain the conservative treatment even after the surgical procedures. Never hurts. People feel great.
Right, right. Phil, what do you like best? When I'm doing a cicatricial ectropion and I have to replace it with a full thickness skin graft, I like the retroauricular tissue. I go behind the ear and I use it because it doesn't have hair on it. Um, it heals great. It's thick. It doesn't shrink. On the really small ones, though, I will use the temporal area on the side. But my favorite go-to is behind the ear. How do you feel about that?
I would agree. I would agree 100%. And when I say 100, I would agree with what you said 100%. And I will say 98% of the time I'm using the skin from behind the ear for everything that you said. And I understand what you're saying about temple, but sometimes, Carl, if people have dermatochalasis and lack skin here, and there's a skin fold right here, sometimes I take that and I'll actually rotate that down. It's not necessary. You can maintain a small pedicle, and if there's a tiny blood vessel in there, it's pretty healthy. But I'll use this excess skin laterally because I always love to say there's nothing like replacing eyelid skin than with eyelid skin. And
Perfect.
people do like the aesthetics of the contour of the lateral canthus or of their upper lid because the excess skin is gone. So sometimes you're exactly right. If it's small, I can use that. But 99% of the time, I'm using the retroauricular skin. Works great, looks great, the color's perfect, and no hair, and people are very, very happy.
Right, right. I did want to say one thing. You know, I see folks say 10 years after a basal cell was removed from the lower cheek and by a plastic surgeon, and I don't want to pick on plastic surgeons because they're great, but you can get that cicatrization or that pulling even years down, a decade, 12, 15 years down the road. And people say, I don't know, why it happened, doc. Tell me why it happened. A lot of times it's prior surgery that just took years and years and years to pull down, and then it requires that replacement of volume that was removed during, say, a small basal cell or a skin cancer excision many years ago. So I do want to highlight that point. Also, Phil, the way I look at it, and hopefully for our audience, you did a fantastic job, but I think of the eyelid like a hammock, and you got an inside part and you got an outside part, and you want to tighten the hammock from sometimes both ends or one end, depending on where the trouble is arising from. And, you develop a plan to remedy the situation. And like I said, it's nice to picture it like you're fixing a hammock or you're tightening a hammock.
Mhm.
But
Perfect.
yeah, so great job. John, anything you want to add?
I'm hoping my internet's good. Can you hear me pretty well?
You're good, John.
Okay. Yeah, I'm curious. When you do an ectropion repair on a 62-year-old, what's your expectation? How long it'll last?
Well, I'm sorry, John. All I heard was when I do an ectropion on a 62-year-old, and then I
How
lost you.
long will it last?
So how long will it last? So I'm going to do everything I can to fix the hammock and tighten the hammock, as Carl said. And I personally try and gingerly over tighten. So I'll slightly overcorrect the ectropion, and people sometimes can see a little bit of excess tightening medially and laterally. Because as Carl pointed out, no matter what, gravity and time is going to play in a role, and you can do the best surgery in the world, but everything kind of goes south. So the proteins are going to loosen, tissues is going to soften, it's going to come back. But I would say from just a ballpark, 5 to 10, 7 to 10 years is where you can see an ectropion stay in place if you appropriately put sutures and do your best job. But I will say, with the patient's help, maintaining eyelid hygiene is so important because it reduces the inflammation, therefore reduces the swelling, therefore reduces the eye turning out.
I agree, Phil. That's a great number. Yeah, I use dissolvable stitches. The procedure itself takes, it can take anywhere from, I don't know, 8 minutes to 15 minutes, something like that, under local anesthesia.
Exactly.
I hate to minimize anything, but it's not a super complicated process. The medial ectropion can sometimes get a little tricky because the lower lid retractors have to be appropriately reinserted back on to this thing called the tarsal plate, which provides the rigidity of the lid. But yeah, I think that's a great job. Listen, guys, thank you. Always great to see my two favorite ophthalmology people from back at Albert Einstein College of Medicine with Ron Bird, our great
Legend.
chief. Rest in peace, Ron. But Phil, incredibly informative. Thanks for breaking it down so clearly. And John, thanks for being here.
Thanks.
To all our viewers, please subscribe, comments. We love your comments, and share this, like. And guys, we'll see you on the next one. Phil, we're going to have you back again because we love having you, and so does our audience. All right, guys. Peace.
Good luck. Thanks for having me, guys.
Thank you.